Great. Well, welcome everyone who is here with us live and those who stream later. Thank you for participating. Thank you for listening. Today, we have a really great panel discussion, and we're talking about the importance of the child fatality review process. And this is hosted by FACT, Family and Children's Trust Fund of Virginia. So as a brief overview of what the format will be, we will have the speakers introduce themselves. We would do some background information, and then we'll go into a question or answer portion where we have some prepared questions. And after that, there will be some follow-up questions. If anyone from the audience has any questions that they would like answered, you're free to send them in the chat and we will certainly get to them. We will have 5 to 10 minutes at the end for any additional Q&A questions, but you are welcome to send along any questions as we move through the program. So I will give the floor over to our speakers so that they can all introduce themselves. If you could just share briefly your name, your affiliation, what organization you're coming from, and your role there, so that we can understand exactly who is in the room and who will be speaking today.
You want me to start, Stephanie?
Sure.
Okay. So my name is Ginny Powell, and I am on the FACT board, the Family and Children's Trust Fund, and I co-chair the Child Abuse and Neglect Advisory Committee. And I'll give a little bit more background, my background and interest in child fatality review when I make my presentation.
I'll go next. I'm Heather Board. I'm the director of the Division of Prevention and Health Promotion here at the Virginia Department of Health, and have been a member of the state child fatality review team. I believe it's been since around 2007. And did participate on the Central Regional Child Fatality Review Team as well.
Good afternoon. My name is Eric Reynolds. I'm the director of the Office of the Children's Ombudsman. It's a fairly new office created 2 years ago. Part of our duties on the statutes that created us are to investigate child fatality cases involving children who had previous or whose families had previous involvement with CPS or foster care in the preceding 1 to 2 years prior to the child's death. I'm a member of the FACT Child and Abuse and Neglect Committee, as well as the Children's Justice Act and CASA Advisory Committee as well.
I can go. Hi, I'm Ryan Dydick-Smith. I'm the director of the Division of Death Prevention with the Office of the Chief Medical Examiner's Office. We have the Child Fatality Review Team, the state team that Heather mentioned. We also provide technical assistance and training to our regional child fatality review teams. And we also have the Sudden Death and the Young Project, which also has a fatality review component. And also joining me in a few will be Tricia Smith. She's our Family Violence Programs Coordinator, and she oversees all of the family violence and child fatality programs here at the state. And actually, Ginny was in my role before she retired several years ago. So it's good to see you, Ginny.
Good to see you.
I can go next.
Oh, go ahead.
I'm Judy Kurtz. I'm a member of the Eastern Region Child Fatality Team, and I used to be the coordinator for the Sudden Death and the Young program that works out of the Medical Examiner's Office. And I was also a member of the FACT board for 8 years. And I used to run the CASA program here in Virginia Beach.
My name is Carly Lanson. I'm the State Child Fatality Specialist with the Virginia Department of Social Services. I am under my supervisor, Shannon Hartung's team, the protection team at VDSS. I also sit on the State Child Fatality Review team, and I assist our regional practice consultants with their regional child fatality review teams as well.
Great, thank you. So those were all of our speakers. My name is Stephanie Howard. I will be facilitating the conversation today. I'm an assistant professor with Norfolk State University with the School of Social Work. I also serve on the FACT-CAN committee and the Eastern Virginia Child Fatality Review team. So we appreciate all of the diversity of experiences and perspectives that we'll hear from today. Just to give us some background information and really help to orient us to the topic, we're going to have some brief remarks from Jenny.
Yeah, okay. Yeah, I'm going to just give sort of some basic definitions and some background on the child fatality review processes in Virginia. I should tell you that I'm trained as a sociologist and a demographer, and I taught in colleges and universities in the Midwest and just a little bit in Virginia before I joined the state of Virginia, first in the court improvement program at the Supreme Court, and then in the medical examiner's office as the second child fatality review coordinator. I followed Suzanne Keller, who really got the process started. And I ended up being the program manager for all of the fatality review and surveillance programs until I retired. So just wanted to let you know that the state team in Virginia was established in 1994. So it has been around for 30 years, which sort of blows me away. And local and community-based teams were put into legislation in 1999. So they're about 25 years old. So they have a long history in Virginia. We were among there is a group of people who get together who actually started some of the fatality review and surveillance programs in the medical examiner's office. One of them is Dr. Marcella Fierro. So we get together quarterly, and they call themselves the founding mothers. But there is one man in there too, who founded many of these programs and worked with the legislature. And so I saw them the other night. So I talked to them a little bit about kind of what was going on. What they said is that Virginia was sort of in the 90s when all the states were sort of getting interested in child fatality review teams. Virginia was about in the first third. They weren't in the last. They weren't pulling up the rear, but they weren't sort of the first state to do this. But it's pretty much widespread in the United States. Most states have teams that are strong and operating well. And sometimes they wax and wane, but they have teams, and also that we have state child fatality review teams in our territorial areas of the United States. So what is it? Okay, and how did it get started? So death review has a pretty long history in the United States. Its most common uses were actually in a medical setting and in industrial settings. And these were private and not publicized. They were essentially, how can we do better if the surgery wasn't working correctly in this particular case? What can we do better the next time? And also to prevent injury and death on the job. Okay, but the child fatality team movement, I guess, that started really in the late 80s and the 90s, was really determined to be a public effort. Right? So public health, departments of social services, in the Attorney General's office, it's really educating people about how and why children die, and emphasizing the fact that much child death is both preventable and you know, we can do something, we can make a difference. It's both premature and it's preventable. So our efforts were really in Virginia and elsewhere to create information for our states and to advocate for changes so that children were safer and lived. They did not die these premature deaths. The other thing about child death, besides I forgot a P, the third part of the fact that it was preventable is patterned. It's a pattern of death. Okay, so we know there are unsafe sleep deaths. We know there are drowning deaths. So it's not rare enough. It's not a rare event, and we can kind of describe it and narrate it and do something about it. So just to say a little bit about the membership of teams, it was really important from the beginning that team members were from many disciplines. Children meet, you know, and they encounter many systems. You know, it could be a school system, a pediatrician, an EMS provider, an emergency room person, a firefighter, all these sorts of people, a psychiatrist. And so you want those folks at the table to really help to interpret what happened when a child died and kind of help the teams to make good collective recommendations as a collective that will make sense, essentially. So they're multidisciplinary systems with many eyes on the case. There are many eyes on the case. Okay, so the state team is appointed. Many of the seats on the state team are appointed by the governor, and these are like EMS, a pediatrician, a seat for the Medical Society of Virginia, a firefighter, EMS, these sorts of a local Department of Social Services representatives. So all of these folks who may encounter children in part of the system where children will be encountered. And then there's representation from several state agencies like Criminal Justice Services, the Department of Health, behavioral health, those sorts of things. And then additional expertise can be added when they're to kind of help fill out a review. So I can remember at one point, the team was reviewing overdose and poisoning cases to children. And they wanted a toxicology. So the toxicologist in the poison center basically sat on the team for that review. He may still be sitting on it for all I know, but he is okay. So he stayed on the team and essentially really helped the team, you know, to understand what was going on in these overdose cases. Okay. Essentially, the state team selects a focal topic for their review, collects records in those, identifies the children who died from those deaths, and then basically collects records and reviews those records. And I believe the State Child Fatality Review team in Virginia was one of a very few number of teams where the team members actually read the records rather than having the record extracted by someone, but they actually look at the records themselves. And that has been a very unique characteristic of Virginia's team for a while. Carly's going to talk more about the regional teams, but I'll just mention that we have 5 regional teams that are associated with 5 Department of Social Services regions in Virginia. And they review cases that are investigated as suspicious for child abuse and neglect. They are led by DSS, but they are also multidisciplinary. And they have a very different focus when you compare it to the state team, but it's a complementary focus. Okay. So, and then the essence of what I'll say about what I think the contribution of fatality review is, and you'll hear many other people say this today, you're really trying to answer the question, who met this child along the way? And so you're asking for records from the pediatrician, from the medical examiner, anybody who would have been in touch with the child and his or her family. And you're asking the question, did that system or that person have the appropriate law, policy, training, support to help that child? Okay, so that's really what you're trying to, so who met them? And we're going to see what they said in their records. And then the team is going to evaluate whether or not that was a reasonable response given their own expertise. The discussions are extremely rich, and they're intense. They can be very, very intense, as you can imagine. It's the days when we had child fatality review, it was a heavy weekend after that. You know, some of the cases that you read. In their review, besides talking about these systems issues, the other thing the team does is really try to identify opportunities for intervention and prevention. And so that's, the reports will feature a summary of their data and then their ideas for prevention and for improvement, and that those recommendations will sort of have that as the content. And I'll give you just a simple example, and then I'll sort of be done here. The state child fatality review team reviewed deaths to children in hot cars. Okay, and these are children who are typically toddlers, 4 and under. And there were 3 circumstances. It was a very small number of cases over, I think, maybe a 7 or 8 year period. There were kids who were intentionally left in a car. And this had a lot to do with childcare issues and lack of childcare. There were children who were unintentionally left in a car. And then there were children who got themselves in the car. And then their family did not notice they were gone or did not look in the car when they were looking for their children, and they ended up dying. Okay, so those were the 3 circumstances that the state team, how do you help people not forget? How do you address issues of childcare when you don't have it? You know, and then what do you do about keeping kids safe from cars? Okay, that's all I have to say. I'm happy to answer any questions if anybody has a question for me.
Thank you. So that was a great introduction to our topic. So we're going to go into the question and answer portion. We have some prepared questions for the speakers. If we could, we're hoping to keep this portion to about 5 to 10 minutes per person.
Okay.
So naturally, Jenny, you mentioned the regional team, or the regional reviews, and you mentioned Carly. So we could jump to Carly and start a discussion there about the regional fatality review teams. And if you could explain to us, in the last few years, what sort of cases have the regional teams been seeing?
Sure. So like Jenny mentioned, our regional review teams sit in each of our 5 regions across the state. These review meetings are really led by our practice consultants, our CPS practice consultants within each region. The goal of those meetings is really to come up with recommendations on prevention efforts. So at the end of a review, we're asking, could this death have been prevented? And if yes, how so? And developing recommendations from there. So in the last couple of years, the regional child fatality review teams, well, I should start by saying that they review every case that's investigated by a local Department of Social Services. This number is different year to year. I took the average over the last 3 years, and it's about 158 deaths per year. And it is important to note that a fatality isn't reviewed until all court proceedings have concluded, if charges were filed as a result of that child fatality. But they do review all of the cases that are investigated by a local agency. The majority of our child death investigations in Virginia are unfounded, meaning that the investigation lacked a preponderance of the evidence to warrant a disposition of founded. So, for example, in state fiscal year 2022, we had 164 investigations. 101 of those were unfounded. Of those unfounded reports, 75% involved a child less than 1 year of age, and 60% were sleep related. These numbers really are consistent year to year. Our age group of 0 to 3 continues to be the most vulnerable to die from abuse or neglect, and Virginia continues to see a high number of sleep related deaths. 54 of our investigations during state fiscal year 2022 were founded. Of those founded investigations, 65% of them involved physical neglect and 30% involved physical abuse. So, in summary, many of the cases that are being reviewed regionally are cases that have resulted in unfounded disposition and or the victim child's death was a result of physical neglect.
Thank you for sharing that information. Do you have any research that delves deeper into any trends, that comes out of the data?
Sure. We've identified quite a few trends in our review work, actually. Again, because the number of sleep-related fatalities are so high, we've really started to pick apart that data a little bit. And we're looking at a couple of things, especially on these sleep-related ones, because they are such a large number. But we're trying to identify if a safe sleep space was present in the home. Were parents aware of or educated on safe sleep practices prior to the fatality? Was there a substance use component? And this could mean that substance use was occurring at the time of the fatality, the parents have a documented history of substance use, or the decedent was born substance exposed. We're noticing that many of our sleep-related deaths have one or more of these factors present at the time of the fatality, or parents are saying, yes, we were educated, or yes, we did have a safe sleep space, but it wasn't being used for a number of reasons. Some of those questions that we're looking at aren't always known at the time of intake, but could be learned throughout the investigation. Another trend we've noticed is that many of the families identified in a child fatality investigation have active or prior child welfare involvement. So again, our most recent data that was published in state fiscal year 2022 told us that 52% of our families who were involved in a fatality did have prior history. And again, that 50% number is pretty consistent year to year. We consistently see that about half of our families involved in a fatality investigation have prior CPS history.
This is very helpful information. Can you tell us more about the impact of, so Jenny mentioned we've been doing these review processes for many years. Have you seen an impact on your agency or the cases? Does the data show that there's been an impact of these review processes?
So I think the impact we've had at the state level has really been trying to lift some of those recommendations up. So those regional review teams are making recommendations, and we're really trying to initiate some more prevention activities. So just recently, we've developed some educational infographics on safe sleep practices, gun safety, and water safety, because the numbers indicated that there was a need for all three of those topics. All three of those resources were made available on our public website, and they were also made available for our local agency staff to order. So once they were published and shared, we encouraged our local agencies to display those infographics in their offices, share them with the families they work with, and share them with providers in their communities. Another recommendation that came out of many of our regional review teams was a need for more collaboration between CPS and law enforcement during a child death investigation. So in response to that, we worked really closely with the Department of Criminal Justice Services and developed and implemented what we called the Child Death Investigative Protocol. So this protocol calls for a uniform and collaborative response to death investigations between CPS and law enforcement. In addition to that, VDSS has created their own 2-day training for local agency staff specific to child fatality investigations and VDSS guidance around those investigations. And we've included that child death investigation protocol into our training and have made it available to all of our local agencies as a resource. I think another impact that these reviews have had is the need to collaborate with our community partners. So we work really closely with the Department of Education, home visiting agencies, our benefits coworkers, with the hope that this specifically safe sleep education is reaching families who may never come into contact with the child welfare system, or that the education is at least being provided prior to child welfare involvement. And the Department of Education has been a great partner in this work with us, and they share all of our infographics and educational materials and their weekly newsletters to their child care providers. Our own public affairs team maintains a yearly calendar where they're pushing out our resources all year long, but specifically water safety goes out a lot more in the summer months. Our safe sleep education goes out a lot more during SIDS Awareness Month in October. And at the local level, we've noticed that a lot of local agencies are doing really fantastic work around the prevention of child fatalities. We actually have an upcoming meeting where we're highlighting a few of those agencies who continue to do really great prevention work. Again, a lot of it is around safe sleep because those are just the highest number, or, that's where the need is. But some of those activities include utilizing safe sleep checklists during home visits. They're promoting safe sleep on their own local agency social media sites. They're providing materials to families, onesies with creative messaging on it or pack and plays. And there's one agency that even provided a local hospital with an iPad that had safe sleep videos preloaded that they're able to share with new parents. So I think the impact of these reviews is that we're seeing a lot of the same trends over and over again, and then we're trying to lift those prevention recommendations up at the state level and at the local level as well.
Great. I think that was a lot of really helpful information, and I'm certain we will return for some questions. But let's move to, since we've talked about prevention, Heather, if you could share with us about some of your involvement and how it has changed or impacted your career trajectory and the work that you do.
Sure. Thank you for the opportunity to talk through this. As I mentioned, I've been a part of the Child Fatality Review Team since around 2007. And I feel that this is probably, out of all of the work groups or task forces and things that I participate on, this really helps what I learn and take away from the fatality review probably has more of an impact on the work that we do at the health department. So I'll take, for example, kind of building off on the conversations around safe sleep, a lot of our prevention efforts originally focused on, promoting education, best practices, distributing pack and plays, kind of the more traditional approach to prevention in the public health realm. But when we did the review of sleep-related deaths, it became really clear that these families that we were seeing involved in these deaths, the reality was that their environment was very chaotic. And so when you think realistically about kind of their ability to all of the time implement the kind of best practices and things like that, if that's kind of all we were providing, we were continuing to set them up for failure. Because in many cases it was an unrealistic expectation given the reality of many of their situations. And a good portion of what our program did was provide money to community-based organizations to distribute pack and plays to ensure that there was a safe sleep environment available. But in this review that we did, it was identified that of all of the sleep-related deaths, 75% of them had a appropriate sleep environment, whether it was a crib, a bassinet, something like that. It just wasn't being used, or it wasn't being used properly. And as was previously mentioned, we're seeing, again, kind of going back to that chaotic environment, multiple factors coming in and being at play in the situation. And so we really shifted the focus of our program, where yes, we're still promoting and kind of sharing best practices, but the primary focus of our work was connecting with individuals who were touching these families. So for example, working through our Resource Mothers programs, where they could talk through and realistically share information and practices that could be implemented by these families. And some of this really boiled down to having families understand why some of these safe sleep practices are so important. In working with resource mothers who are also promoting breastfeeding and things like that, occasionally, there are kind of conflicts with the breastfeeding community and the safe sleep advocates, because there are certain advocates of breastfeeding that also promote co-sleeping because it facilitates breastfeeding. We were able to work with and talk with some of these breastfeeding advocates, attachment parenting advocates, and were able to realized that in many cases they weren't promoting, shared sleeping environments all of the time. They too were saying, hey, there are times where it's especially not safe, whether the child is sick, if there are some sort of substances in use involved by the parents. So we were able to kind of work with different groups to bring in an understanding of how individuals like resource mothers, doulas, and other entities that are touching these families could have some realistic conversations, so that the aim was to better educate the parents, not just on what the best practices were, but actually on why they were best practices. So then the parents could make an informed, knowledgeable decision, in a situation where perhaps the ideal sleep environment wasn't feasible. So it was about minimizing risk. And so I use that as an example, because without the in-depth work of the child fatality review team in really being able to get a glimpse into, just a snapshot into the lives of these children and the families, that really helped inform how we structured and shifted our program so that we could hopefully work on preventing these types of deaths in the future. So just one quick example about, I think, how powerful the work of this team is, and how it really can impact change.
Great. That was a really great example. We see how the insight is able to transform the services. Could you share a little about where we need to go moving forward, in your professional opinion? What improvements needs to be made? What's the next step for this process?
Sure. So I am a big advocate. I don't know. I believe Virginia is still maybe one of the few states that identifies a specific topic area. So unlike the regional teams where they're reviewing all of the deaths that are happening, picking a specific topic, I think that really helps identify those trends and patterns, so that we can craft, I think, really meaningful recommendations, because we're really focused in on that, instead of kind of jumping from one mechanism of death to another mechanism of death. So I think that is crucial for continuing. It is challenging when requests from the medical examiner's office out to organizations to provide the records are not honored, because we end up missing kind of critical information about, as Ginny mentioned earlier, how these families are interacting with systems that or other people that could help with that. So I'm not exactly sure kind of what could be done, but being able to I don't know if it's push a little harder, or at least have maybe there's an additional education that has to be done with some of these organizations about how important it is when those requests come in from the medical examiner's office to honor them and provide those records.
Great, thank you. So we will certainly touch on some of these ideas, and we'll be back with you with additional questions. So we appreciate all the information that you've shared. Maybe we continue with the Department of Health, and we can move to Ryan.
Good afternoon. Sorry I'm not again on video. Our network in my office is extremely wonky today, so keeps cutting out, so I apologize. But yeah, so sorry, and could you repeat the original question? I've kind of been listening, and what was the original question to start with?
You know, I did not ask a question, so
Okay,
that might be helpful. So if you could talk to us about the trends, the cases that you've been seeing in the last few years, what has been on trend?
So it's important to note that a couple of things before we go into those trends. So while we have a lot of multidisciplinary team members for our state fatality review team, the facilitation of that team comes out of the Office of the Chief Medical Examiner, primarily out of the Division of Death Prevention. And the chair of that team is our Chief Medical Examiner. So he is the chair of the team. He kind of presides over these meetings in a way. He's also a medical examiner, so he can give input on the medical examiner. We also do have another medical examiner who spends, not board certified in it, but she spends a lot of time researching child cases. So she's become a really good advocate and a really good person to have on our team, as she has a lot of experience doing autopsies of these child deaths. To note some of our process, so, you know, we here the centralized location for all of the information that's received related to child fatality. Our team reviews cases of children that fall under the jurisdiction of the OCME. And then from there, like mentioned earlier, we identify based on trends what is happening across the state related to child death. So before we do any sort of review, we look at the trends. What has happened in the last 5 years in Virginia? What has happened across the country? What review topics have we done in the past? What is necessary? What maybe we haven't done, or what might need to be redone because it's been a while and we're seeing an uptick in those particular cases. So for example, we just finished a little while ago a review of suicide deaths through the year 2016. And that was similar to a review that we did 2000, so 16 years prior. And occasionally we do that because either the issue is not, I wouldn't say resolving, but there's been a flat line. So is there anything new? Maybe there's an uptick. And we compare it to the fatality review that we did in that year. So that is something that we're working on. We're finalizing the report and recommendations for that now. And then again, like I said, we look at what's happening across the state, what's happening across the nation, what is something maybe we haven't done that can add to this process. So just for note, right now we are reviewing deaths that occur in a child care setting. And so we have, those are through 2022. And one of the reasons that this was selected is, you know, we go and we present all this data to the team, but there was some strong interest in this review because it's not something that's been done before, but there was a lot of question pre-post COVID. Have there been an increase in deaths? What was the impact of COVID? If there was, what is the landscape of childcare in the state of Virginia? And DSS was instrumental in that process. And then now it's Department of Education. They've taken over the licensure. But, you know, what is going on? And it's not something that we've done before. It's also a very broad systems approach to fatality review, which is we always look at the systems, but we're really looking broadly is how did the system impact or what were the contributing factors to a death of a child that occurred in a daycare setting. So we're looking at all different factors, you know, such as socioeconomic, availability, you know, were these providers that had been in existence for a long time? And if they had been, were they receiving, you know, safe sleep education? If it was a sleep death, were they working, you know, did they have following the legal rules? Because there are rules about unlicensed daycares that are considered legal, like if you have less than 4 or less children or not. So we're looking at all of these deaths. So it's really a process, and that's how we decide. And then I just want to address the comment about the change because Ginny had mentioned that the team members review the team. During COVID, post-COVID, that process has changed. And there are several reasons for that. And there is value in both, as Betty Wade mentioned, there's pros and cons. But we're piloting this new process where our family violence program manager is collecting all of the records, extracting information, creating summaries from all of that information, and we're giving it out to the team for review. And that was for several reasons. There has been an increased push for timeliness of review. Like I mentioned, the suicide review, the last year of data that we were able to review was 2016, but from a top-down level, there's been this push for more timely review. Not only so that the information is the most current available to us, but also so that we have that intersection of providing change. And, you know, if we're going to implement change, we want to do it as soon as possible. So we want to have some timeliness of review. There are some concerns with privacy. We've also had, over the years, there's been some difficulty with team member ability to read, interpret, and abstract some of that information. And, you know, so we are trying to relieve that burden on them. And then, again, the timeliness issue. So we're piloting this with the daycare review. Our family violence program coordinator, who is Tricia Smith, she's actually, like I said, in the room with me today. We've been tracking our record request process as well, and she has about a 99% response rate of getting the records that we need. We typically run into issues with Department of Corrections and FERPA. So those are the two biggest ones, but in terms of getting records, she has been extremely successful, even down to we've struggled in past years getting court records, but she's been able to make connections with the court systems, with the clerks, and explaining, you know, what we're doing and what we're looking for and getting court records that we haven't been able to see before. So we're piloting this, we're seeing it, but we've seen some great change. And of course, because we do have team members that may want to still be a part of the initial review process, they are more than welcome to participate in that process. You know, it's not a secret process. They can definitely review the record if it's particular to their particular interest. So, and then, so all of this, and then what we do is, you know, as Heather has mentioned, we take these recommendations from the review, we look at everything that we can possibly do, our team adds the input, we kind of get what were the factors that contributed to the death, was the death preventable? You know, again, many of these deaths are preventable. Was the death preventable? And then lastly, we write recommendations. And then for us, some of the prevention strategies that we've been successful in supporting, and since we don't do programs, so we're not implementing these programs, but we definitely want to work with, we want to work with our partners. So the DCJS training, or DCJS training that Carly mentioned, that came from one of our recommendations. And then we've been working in the Tidewater region with an agency called Birth 9 to 5. They are a large, diverse, multidisciplinary group in that area to address safe sleep. So those are kind of how we approach prevention, because we're not going to go out and implement the programs, but we still want to work with partners to take these recommendations and implement them. So we're working with them. We're in the early stages of working with Birth 9 to 5. They had quite a hiatus after COVID. They're coming back. They just had a big kickoff meeting back in July. And so they've been taking a lot of the information that we've been able to provide them in order to address safe sleep, because as Carly said, it's still a large issue. So that's our process. In terms of trends, I mentioned that we did see an uptick in childcare related deaths. So that is a trend. In our Tidewater region, where we have the Sudden Death in the Young project, which is separate from child fatality, the state team, but it does have a fatality review component encompassed within the regional review team down there. We see a lot of sleep related death. So we're still seeing those trends. And that project is aimed at more of the, for our state, more of the local level, change. And actually we're excited because we're hoping to receive notice soon. We're still waiting, but it should be soon, to see if we're able to expand the SDY project into our central region as well. So it's encompassed there, but again, adding another fatality review component by adding an additional team in the central region to review what we call the sudden death in the young cases. So we've had a lot of change over the last several years. I came on board in 2017. Trisha came on board in 2019. And we've had a lot of growth and a lot of change, and we're excited to see where this takes child fatality, while still staying true to, you know, the tenets of child fatality, which is, you know, to prevent child death. So it's been an exciting time. And yeah.
Well, thank you. So certainly we'll want to hear more if we have time about, you know, how you guys are expanding and growing. But could you tell us about some current concerns with regards to the state team?
Could you elaborate on that in terms of what by concerns of the state team?
Sure. So does your department, does it have any current issues or barriers, or are you encountering any problems or concerns, areas where you would like improvement with regard to the state team?
No, I mean, we've been doing really well. And so no, I don't think, like I said, if anything, we're really moving. Yeah, I was going to say, Trisha's over here telling me streamline the process. You know, we've gotten better at streamlining that to get the most records. You know, we're working closely with, in the past, we have had some issues, not necessarily getting the records, but the timeliness of getting the records. And so we've been working with agencies that provide the records often. You know, getting them. So a lot of times we're able to, you know, we do a lot of mailing, but some agencies have said, hey, we have this online portal. Here's access to the online portal. The courts are working with us to allow us to send requests through an online portal. A lot of the medical providers that we use, the hospital system, some social service agencies are using these portals. So in terms of streamlining, we're really trying to find ways to, again, going back to that timeliness piece, which is so important, of how do we get these records. So we've streamlined a lot of the process. We're able to, even in terms of having records ready for review. So, you know, in typical review, we like to do at least 4. So it's been really helping us with these new processes that we've implemented, getting those cases prepared. So every single meeting can occur because we have cases to review. In the past, it sometimes, you know, depending on the time of year, and people are extremely busy and they have, you know, a lot of competing responsibilities. There have been times where we've had to cancel meetings because nobody was prepared or we weren't prepared to present. So we've really worked hard to streamline that because we want to make sure that we're reviewing, you know, we try to do 4 cases a meeting, which is 24 cases a year, and a team really can effectively do about 30 to 40 cases in a review cycle. So we're just staying on that. So I wouldn't say there's any barriers or issues. I think what we can say is that we're very proactive when there is something that may be presented to us as a barrier, that we address it and address it quickly as we can. And then also, like I said, working with, our partners, and we've struggled with courts. And like I said, Trisha's been, she just called up one day and said, hey, how do I get these records, and explained it. And the person that she was working with was like, oh my gosh, yes, I can do this. And here's how we can do it. And, here's my contact at another court. And so we're doing those things. So that is one of, I don't say, like I said, we don't really have any barriers or issues, but it's definitely something that we're always trying to address and to stay on top of, so it does not become a barrier or an issue.
Well, thank you for sharing. We will definitely touch back in with you. But for now, let's move to one of our newest departments involved in this process, the Office of the Children's Ombudsman. Eric, if you could tell us about your experience coming in from this perspective, what are your initial observations?
Well, again, this is a fairly new office. 2 years ago, it was created, or I started it. And, most of what we do is we review the actions of local departments of social services with regard to child protective services and foster care cases. With regard to child fatalities, our statute gives us the authority that we may investigate child fatalities, cases that occurred or alleged to have occurred due to abuse or neglect of a child when there's been some history, either active CPS or foster care history, or history within the previous 1 to 2 years, depending on the situation. So we're primarily concerned with the actions of the local Department of Social Services that had touched this family prior to the child's death, and what was done in regards to those cases. Was it related to the issues that led to the child's death? Those kinds of things. And because we're so new and resources aren't quite as where I need it to be, we haven't been paying a lot of attention to these cases, unfortunately. I am keeping track of everything that VDSS, the Virginia Department of Social Services, provides us, and thanks to Carly, who is our contact person over there, who provides us the notices of the child fatalities that meet our statutory requirements for us to review. So we keep track and keep tabs on those cases, and I do take a brief look at the cases to see if there's something to them, or if there's something that we need to dig down a little bit more deeper. Unfortunately, just don't have a lot of time or resources to be able to devote to those, but we're building that up. But in the review of the cases that we did look since this office has started, I think some of the things that I've noted, the number of unsafe sleep situations, the number of children under the age of 6 months that are dying, and specifically the kids who have touched the system prior to at birth, either being reported as substance exposed, or maybe there was a call from hospital staff or medical staff about the condition of the parents, the parental substance use that was going on, that may have caused them concern to call CPS and say, we're not entirely sure it's safe for this child to go home with this family. And so those are the cases that really have stood out to me in looking at the cases that come to our attention. What took place when that child was born? What actions were taken? Are our laws pertaining to substance exposed infants, and those reports that are made when there's that suspicion, or when the child is exhibiting, certain symptoms, withdrawal symptoms, or what have you at birth, are our laws and policies good enough? Why are these kids falling through the cracks? What's going on? Is the agency involved? And despite the agency's involvement, these kids are still dying. What's going on here? So those are the cases that really I've called attention to, just because, are they preventable? What happened for these kids to fall through the cracks like that? So those are some of my observations, and those cases continue to come in, as a lot of the folks that are involved in this work know. That those are some of the circumstances that we see over and over again, and how much of these unfounded fatality investigations, or how many who have been determined to be due to unsafe sleep or accidental or not necessarily so. Maybe there was more information behind it that, was it the substance abuse or was it mental health circumstances, or as Heather talked about, the chaotic environment in the home that led to it. And we just can't confirm that, these deaths were not accidental, I guess. So those are the cases that really I've called attention to myself as far as paying attention to.
Thank you. So we understand that this is relatively new and your recommendations haven't necessarily been developed. But as you are hearing the information and receiving the data, do you have any questions or concerns that maybe are a little preliminary, or is there an area where you would like to see improvements that you started to identify?
Well, I think again, the substance exposed infant laws, that we changed about 5 years ago. And it was a group effort. I think there are a lot of healthcare professionals that were involved in the development of the statute, in determining the language to be used. I think there's some really good state guidance from VDSS about how local agencies should be following or should be handling these kinds of cases, what to do in these circumstances or those circumstances. So I think there's some good policies in place. Again, what is it about it that is failing here for these children to be falling through the cracks? And I did have some conversations with some medical professionals who are very sensitive to this area, this topic. And, there's the voluntariness of this process. We can't force some families to do certain things. We have to rely on them agreeing and consenting to accessing services, whether it's, home visiting programs or nurse home visiting programs, or infant and toddler connection, making those kinds of connections. It's all based upon the voluntariness of the family. And what do we do when the family doesn't consent to that? Or the family says, no, we don't think we need that. We don't want to do that, or we don't have time for it. What can we do to help those very vulnerable children in those circumstances? I don't know what the answer is, certainly as a lawyer or a recovering lawyer, I'm not sure what kind of due process issues would be implicated if we were to force families to do certain things. So I think, but it's worth exploring. What are the parameters of what we can do? What are the options within those parameters to be able to help these most vulnerable children?
Thank you. So we will be back in touch with some additional questions, but we have one more speaker. Judy, if you could share, you've been doing some work particularly in terms of sudden death in the young. Could you share some of the findings of your work?
I think, as Heather and Eric both alluded to, there's a constellation or a chaotic home environment has been a huge recognition in looking at these cases. And a newborn up through 6 months or a year, many families elevate that child's care to the top of their list of things to do. But if you're a family that's struggling with housing insecurity, a single parent family, a parent working crazy job hours, can't find daycare, getting ready to move out because you can't pay the rent, you can't elevate that child's care to the top of your list. I think the other finding that was striking to me, and of course all this is preliminary because the project is still ongoing, and we're collecting more information all the time through Trish's office. I'm not involved anymore, but many of the babies that die have been sick babies. So these are babies that are high risk infants even before they're born. So the mothers are having complicated pregnancies, and then the infant's born premature. often has a NICU stay, an intensive care stay, and then they go home. So they're a high needs infant to start with. And then the kids are often sick with the respiratory symptoms, colds, whatever. And then this sort of constellation of chaos happens. And maybe the parent puts the child in bed with them just because they're trying to get some sleep before they have to get up and go to work. And they roll over during the night because they either were so tired they couldn't wake up, or there's some substance use involved. And so their sleep-wake pattern for the parent is not as it should be. And the infant ends up deceased. So I think that's kind of, in a nutshell, what has struck me the most with the work that I did on that project. And this problems are repetitive. It's not just one family that's struggling with homeless housing insecurity. It's not one family that's got substance abuse. It's not one NICU baby. They're across the board. It was very rare, at least in the time I was there, to see a family that didn't have any of those sort of risk factors identified, and had a baby die suddenly without any known reason for it. So I think those two things, the babies are sick to start with, and the families are in chaotic living situations, are two huge aspects to the problem of sudden death from sleep, unsafe sleep.
Well, thank you for sharing. Can you tell us, from the work that you've done, where are some areas where we could improve, particularly as related to the child fatality review process?
I think I can only speak to the Eastern team, which is the team I sit on, and that team has been active. I think it's the longest meeting team in the state. So people have come and gone. I would like to see more diversity on the team. We have a heavy emphasis on social service folks, which is really helpful, I think, because everyone's learning from one another. But I would like to see more regular involvement from law enforcement that's represented in our area. If the case, is of an older child that's not a safe sleep death for somebody under the age of a year, I'd like to see an educator on board. I'd like to see sort of a more representative group, kind of that sits at the same state level, be available at the local level to do some of those reviews. Because we've had an EMS person on our team for a while, and every time he asked a question, it sparked a whole rich discussion about something that I don't know that any of us sitting in with wearing different hats would have even thought of, and yet it was informative for the whole group. So I'd like to see more diverse representation.
Thank you. So I appreciate all of the information shared from the different speakers. So we have a couple of questions. One question that's come up a lot in the chat, and that seems to be a theme, is that there's a lot of insight that's gleaned from the process, and some really great recommendations. And how are these recommendations developed? What kind of report writing? What kind of how we developing and disseminating this information broadly? So that can go out to anyone, and then we'll kind of pop around and respond.
So this is Ryan. I can talk about our recommendations process a little bit. So how the recommendations are developed is we take all of the thoughts of the team, all of their recommendations that they've made over the review, and we do like a thematic analysis. We find similarities across the recommendations and we categorize them. And then while we're categorizing them, we're also looking at them. Are they towards a particular agency? Is it a broad policy recommendation or a broad programmatic recommendation? After we do this thematic analysis, we kind of parse down, because there's a lot of recommendations over the time, and I'll say, we need to get, I'll just say FERPA. FERPA is school records, and FERPA has been traditionally the hardest for us to get. It's a federal federal statute, and some, a lot of schools just tell us it's FERPA and they can't get it for us or give us to us. So, one of the recommendations has been school records. And so, every review, it'll be like, we need to draft a policy related to school records, So we don't put all of the recommendations necessarily and say 52 recommendations. Or we say there's, this recommendation was made to address the need for school records. And, this is the suggestion of how we would recommend this be done. So once we create these recommendations, we present them to the team and we ask the team to look at them and tell us whether or not, they essentially have drafted them. So is this what they were thinking? Is this, does this need to be tweaked? What were they thinking? Is it under the right agency? Is it under the right heading? Is it directed to the right person? We also ask them to look at the recommendations in terms of what is the low-hanging fruit? Because, sometimes they are expensive ones and there may not be funding. So is there something that they could do, like a telemessage or a communication or info brief that's relatively inexpensive but still could have some impact? Or are these, large ones where we would definitely want to still put it in there but work with agencies to implement them and find funding? Once we do all of that, we get the feedback of the team. We actually ask that agencies look at the recommendations just to also too, because if we're going to recommend that the Department of Education do XYZ, kind of need to forewarn that Department of Education that this is probably coming, and also get some of their feedback, because sometimes they'll look at them and say, yeah, this is a really great idea, but we probably should tweak it here. And then we put them in our report. And so all of our recommendations that are vetted and are put into our report. And one area that we do need to do better at is following up with those recommendations to see what recommendations were implemented. It is something that we're also doing with our maternal mortality review team, because again, OCME is not programmatic in that sense, and we send them out and we would like to know if the recommendations are being implemented or parts of recommendations are being implemented. It's like why we're really excited for our work with DCJS, that they said, oh, this came out of a recommendation, or Birth 9 to 5. There was a couple of other agencies pre-COVID that were doing some work that we were working with in order to get more messaging out. So that's kind of so we're working on getting a feedback loop. Will never be a perfect system because there's no requirement for them to tell us, but we're hoping through our partnerships and through our networking that we'll learn. We also look at what VDH is doing as well. And so are they implementing those, or are they even doing things that maybe we can enhance, recommend enhancement on, or support in other ways? So that is how we put them out there. They go out, it goes out on when we do publish our report on our website, it goes out to a large listserv. Team members forward it to their people, so the reach is pretty big in general. And then yeah, so that's kind of how we do our process. Carly can address how they do the regional, or whoever wants to address, because they're done a little bit different on the local regional level.
Before we move on, one quick question. Do you encounter any barriers in the process of disseminating this information or getting the information out to stakeholders and community?
No, I mean, it's very well received when it goes out. We initially get a lot of feedback. We do occasionally get some media interest as well, but in terms of getting it out, we currently with the Child Fatality Review team are not seeing any barriers to getting the information out. Probably our only barrier is just getting it all put together right now. We're extremely short-staffed over here. But in terms of getting it out, disseminating it, reception, stakeholder participation, no, we are not experiencing any of that.
Thank you. Carly, I think you were ready to speak.
Yeah, so each of our 5 regional review teams, they come up with recommendations after they review each case during every meeting throughout the year. And then at the end of the year, our policy mandates that they send those up to me or to Shannon so we can have a good look at all of the recommendations that came out of all 5 regions. From there, we try to identify trends or similarities. A lot of the time there is a safe sleep component, or two or three regions are seeing kind of a similar trend. So we're trying to pull out themes and trends, and we're including those recommendations in our annual report. So the one that just went out for state fiscal year 2022 included the most recent batch of recommendations, but it also included an update on last year's recommendations, what those were and what prevention activities have been initiated, completed, just the status of the year prior. And we get that out typically in August of every year. Again, it's published on our public website, and it goes out to all of our local agencies as well. Let me know if I missed any part of that question.
That was great. Thank you. We have another question here for Ryan. Can you talk with us about how the state supports or provides technical assistance to local teams?
Sure. So to be honest, we don't provide too much to the local and to the regional child fatality review teams. They have been in existence for a long time, and they operate pretty effectively. But how we provide that is in a variety of ways. So there are several statutes for, I'm just going to speak broadly because there are several local and regional teams. We have teams for overdose, domestic violence, adult fatality, and child fatality. And how we provide the technical assistance and training is that if individuals are interested in starting teams, we have some materials that we can provide them. We will also, provide presentations about what is fatality review and what are the, the tenets of fatality review. Talk to them a little bit about how to develop teams. In the past, we have been asked to help. How do we put out a final report? We read all of this information. We reviewed all of this information. What do we do with it now? So we, supported some support in terms of analysis, or in, putting together a report. We worked with teams on providing data. We provide data to localities if they're interested in data, just to kind of get the ball rolling. We also will, sorry, Trisha's gonna, oh yes, and then also too, we are helping regional teams with data collection. It goes into our national CDR child death review database, and we are supporting that work so that their information can be in a database so that we can output it for them. So the technical assistance and training, it's not a real formal process. It's more driven by the locality or the region, and in terms of what they need, because there's varying levels of need. Some of our teams have been around for a long time. They have coordinators who are very well versed in terms of how to develop a team, how to facilitate a team, and they just reach out when things get a little sticky, or we have there is some interest in a new domestic violence review team, and so they've reached out to just kind of ask us questions about what they're doing, how they're doing it. So it's really driven by what their need is, and then we tailor their request to them specifically, because they are autonomous. We do work with them, but they really are their own team and their own entity. So we let them lead that charge and let us know what they need from us.
Thank you. So there's a comment here about a request to have the reports accessible on the website. If the state reports can be made available through the website.
Oh yeah. So our whole website got reviewed, and that was a suggestion to take off, but I can see if there's an availability to put those back on or create. Oh no, actually, I forgot about this. Our reports all went in an archive, so I can get the link to the archive, and that's where they will be. I'll just have to figure out what link that is, but they've all been archived, or what we had available was archived. And that was to just not bog down the website as much. Also, if teams are interested, or not teams, but if people are interested in reports, we do have a catalog of them. We can send them. We actually still have some paper-based ones, some of the older ones. But there is an archive, and I can research that and share with Nicole or Stephanie to make sure that that information is accessible.
So I think that, thank you for that. I think that question kind of gets at a theme that I've heard about community input as well as informing the community. How is the community integrated into this process of the child fatality review process?
That would be done at the local level, more of the community, because they are, so we do have community-based agencies on our state team, but we don't necessarily involve community members such as in a public forum. All fatality review teams are considered confidential, closed. Everyone has to sign a confidentiality agreement, and so they're not public, but we can share the information through data requests. We can also, we put the information out. We have as many community-based agencies as are feasible or appropriate for the review. But I know that the local teams have a little bit more representation in terms of community based participation. Again, they're still closed confidential meetings, but they're individuals and agencies that work at the local level.
So we're almost out of time, but maybe we can handle this one more question. We understand how important this process is, and we want to ensure that continuous improvement. How is that integrated into this process?
I'm sorry, could you repeat the question?
Sure. So how do we work toward continuous improvement in the child fatality review process?
I think one of the biggest improvements, or I don't want to even say improvement, I think one of the biggest things is moving this data to action in terms of taking the data that's available and moving it to some sort of actionable activity, or taking the recommendations and implementing that. And it's such a simple answer to a much larger overarching topic, because there's capacity in terms of staffing, funding. I think there needs to be, we put a lot of policy into place. There's policies in place, but when we're looking at in terms of improvements, it's really moving that data to action. We can research, we can review, we can put out all of the reports in the world, but that actionable piece is what's the most critical in making change. And so I know that's one of our, strategic goals is to work to implement those recommendations, or again, move to an action. And then when that happens, getting the feedback from what the evaluation is to see if it's actually making change. If say sleep-related deaths went down in terms of numbers, we could assume that there was obviously a, looking at numbers and data, but we could say that there was obviously something that triggered that change. What was it? And so we would like to be able to move to that, to be able to say, oh, it was because, after we did this statewide messaging, there was a difference. I actually have some partners at CHKD, and they've done a huge initiative with their messaging in terms of when you're on hold. You're on hold a while nowadays, but they're doing a lot of safe sleep messaging. And I have some contacts over there in the pediatrics department and a couple other places. And I, asked them, I said, hey, there's a way that we could find out if, this messaging works. That would be great. It didn't come directly from our team. We did not recommend that. But, there's a lot of other things. And then also, I think to make it effective is these partnerships. So partnering with local agencies, state agencies, again, like I said, partnering with CHKD to see what their data, if they're able to get this data and see what their messaging is. Has there been and I have to get with them and find out exactly what they're measuring and how they're measuring it. But, has there been a decrease? Are people saying, oh yeah, I heard your messaging while I was waiting to make an appointment for my newborn, and I realized that I was not following safe sleep. So it's really important because, there's a lot of information out there, but I think what the piece is missing, and I think it's something that everybody is striving for, not just the state fatality review team or the regional teams, but the prevention teams, the grassroots organizations, the community-based organizations. What they're really looking to see is what change has been made. And I think that's an improvement area for sure, is how do we all work together? We're all working towards the common goal. And what are those efforts doing? And how are they doing it?
Great. Certainly, we've heard a lot about collaboration, the need for collaboration, sharing information, and working together to make this work rich and productive. So this has been a great conversation. We all have very busy schedules, so we don't want to hold you past the time. But thank you for participating. Thank you for listening. Thank you for being on the line. I've enjoyed it, and I hope you have as well. But I will give the floor to Nicole to close us out.
Yeah, just to reiterate, just to thank the panel so much for your participation and all your great work on this. We're really just trying to increase understanding and awareness of these issues that have been identified by the Child Abuse and Neglect. Whoops, I'm out. I think this has been a great way for us to really start these panels and this work. And I'm sure that we'll have more questions as we move forward and learning more about these issues, and I'll be reaching out to you all. But thank you all so much.
Thank you all, and have a wonderful day. Appreciate it.
Meeting adjourned.